All right, as it's a little after 8, I think we shall get started and I'm sure people will roll in. I wanted to thank Katie for helping out immensely with putting together this presentation, ranging from biopsies to subsequent resections, as well as relevant immunostains. I hope you can all see my screen. I made the presentation full screen, so hopefully that will help enlarge it. We are happy to provide the full presentation, which I'm going to go through today. We only gave you the sort of original or diagnostic, I guess maybe not diagnostic, but the original kind of item that was seen for each case. And today we're going to go over, as I said, both the immunostains and the subsequent resections. So I'm happy to provide this presentation as well, since it's a little bit more thorough. So I think hopefully what we'll do is we'll start with maybe a descriptive discussion of each of these cases, maybe starting with a more junior person, like a first year or even a second year. And then as we go on to sort of interpretation of the immunostains, we can move on to the higher levels. But of course, as usual, please feel free to ask questions, type things in the chat. Okay, so case 1, it looks like we definitely have some first years on there. And this is one of the more common things you might encounter. So might I ask a first year to start with this one?
Hi, this is Brooke. I can start with this one.
Thanks, Brooke.
So on low power, we can see that it's quite blue, but at the same time, there are streaks of pink cells within it. I think if we zoom in a little bit more, we can see that the blue cells are composed of what look like lymphocytes, which are quite dense. And the pink bands are composed of plump oncocytic cells, maybe in a couple of layers thick. Shall I jump to the diagnosis?
Yeah, I think, you know, there are certain cases like this where I think a diagnosis is totally possible on core biopsy, and this is one of them. Sorry about the quality of, I think this might have been a consult recut or something, so it's a little bit poor quality, but yeah, what's your thought?
So these features in the history are very consistent with a Warthin tumor.
Awesome. And this was, oh, I totally forgot the history. A 61-year-old female with bilateral swelling of the parotid for 5 to 6 years. Yeah, so tell us.
So the bilateral parotids for sure are consistent. And then it didn't say in the history, but we'd also suspect that the patient might be a long-time regular smoker.
Right. Awesome. So yeah, I mean, you know, the one caveat I will say is that most salivary gland biopsies happen on FNA, right, rather than core. But core or even shave biopsy of a mucosal site does come through, as you have seen in this presentation. So always be mindful that, you know, the same features that you want to see either on the FNA or on the resection may or may not be present on the core. So exactly. So this is pretty much a classic Warthin tumor. And you can see the same features here recapitulated on a resection specimen. So Brooke, is a Warthin tumor neoplastic, perhaps non-neoplastic, uncertain?
I believe it's considered non-neoplastic.
Yeah, so there have not been any clonal genetic anomalies, or even clonal X inactivation has not been found in Warthin tumor. So unfortunately, we call it a tumor, but it may not actually be a tumor. It may just be oncocytic cystic metaplasia with a lot of background inflammation. But as you said, a nice background inflammatory infiltrate with very beautiful bilayered oncocytic cells with large nuclei, prominent nucleoli. I will mention immunohistochemically, you know, if you were to evaluate this, sometimes this abluminal cell population out here does stain for P63. So even though it looks morphologically like a single cell type, you may actually get some P63 staining at the periphery of these nests. And this is true for other oncocytic lesions salivary gland. So this P63, P40, I'm just going to write P40 here, is present in Wharton tumor, in oncocytoma, and so that can also be sometimes helpful in distinguishing some of these lesions from others. So, okay, questions on Wharton? That wasn't too challenging of a case. Remember that Wharton can undergo mucinous metaplasia, squamous metaplasia. And so don't let, sometimes you can have a challenging case where it's extensively squamoid or extensively mucinous metaplastic. And those can be a little more challenging. Here's maybe a hair of a little bit of squamoid duct right there. Okay. And if you, all right, want to move on to maybe another relatively more junior person to describe what they see on the biopsy.
I can describe this one.
Thank you.
So you can kind of see on the left side, more normal looking glands, mostly serous, but kind of admixed. And then a little bit of like hyalinized area in the beginning of what the presumed tumor is. There's actually kind of a sparse amount of cells and a lot of kind of myxoid area, possibly mucinous, but it kind of just looks, at least in this field, very similar to just the slide itself, very, very clear. And then the cells themselves, sometimes they're kind of like a spindled morphology, completely single, and then sometimes like this, more epithelioid, almost duct forming, usually bilayer E, in a couple areas, maybe the same, but in a kind of different section through it, like cross-sectional versus longitudinal sectioning.
Yeah, there's some maybe plumper epithelioid cells, maybe surrounded by a second layer of myoepithelial cells. Okay. So this was sorry, again, I keep forgetting the history. 55-year-old female with a 1.5 centimeter mass of the parotid gland. So what's your differential, and would you do anything on biopsy to help you out with that?
Yeah, so I guess as far as like thinking of the categories, like it jumps to that. I mean, with all this mucin, it kind of jumps to that mucinous category. But honestly, that kind of looks like the kind of just the largely myoepithelial component of PA. Is what it's reminiscent of to me.
Sure. So just to clarify, let's just differentiate mucin in this case, is this connective tissue or stromal mucin, or is this epithelial mucin?
Well, I mean, it doesn't look, as far as I can tell, intracytoplasmic. Is that the question?
Yeah, exactly. So when you have, epithelial mucin, that would either be within the cytoplasm of the epithelial cells, or even sometimes being secreted into the sort of duct lumen, right? Where versus stromal mucin is that produced by, like you said, more of the myoepithelial cell population and sort of extruded backwards, right? Like out into the stroma. Yeah.
Right. Yeah, I mean, I don't see clearly within, like, so I mean, yeah, I guess the question would be, I would say leans more towards stromal. I mean, obviously, if you did your kind of like PASD stains, and you saw positivity within these cells.
Right. So you're right. So we think this is predominantly connective tissue with stromal mucin, since we don't see any in the cells. We know that these are produced by myoepithelial cells. We vaguely see a bilayered duct-like structure. And so we're, as you said, I think favoring the, myoepithelial rich, stromal rich compartment of a pleomorphic adenoma is a very fine thought process. The important question is, do you see any high-grade features? Lots of mitoses, lots of nuclear atypia, anything that might suggest this to be a high-grade carcinoma?
No.
No. So
Obviously, you can't really, I mean, the closest thing to assessing invasion is kind of that one area of normal we first looked, and it didn't look infiltrative at that area either.
right. But of course, that's only a fraction of the periphery. Exactly.
Right.
So yeah, the word that I will say of caveat here, as I think you will be able to see when we compare this to one of the other biopsies, is, on core, we really try to not necessarily make a firm diagnosis of pleomorphic adenoma, because the morphologic features between PA and the other biphasic, myxoid stromal rich salivary gland neoplasms can be very extensive. So as long as you think, number one, that this is a low-grade salivary gland neoplasm, I think that would be all that would be needed to say on a diagnostic line for a core biopsy. So sort of low-grade, presumably biphasic salivary gland neoplasm, low-grade myoepithelial or stromal rich salivary gland neoplasm, with sort of perhaps favoring PA in the comments. Because again, as you'll see in another case, these diagnoses can be very challenging on core. So to finally go to the resection, I don't even think any stains were done on this, because it was so low grade and so paucicellular. And for a low grade diagnosis on biopsy, the surgical management is what?
Just resection?
Just resection, exactly. So just resection with margin.
I mean, the surgical management implied surgery. So.
Yes, well, generally salivary glands are surgical diseases, right? And so surgical management can range from exactly just resection of the tumor to essentially resection of the tumor plus the neck dissection, if we're thinking about a high grade. Yeah, exactly. So here we have a surgical resection of this particular specimen. And I believe this is exactly the same lesion that we saw on core. It's quite small, and it recapitulates the same features that we saw in the biopsy, right? Very myxoid stromal rich, very bland epithelioid or spindled cells, like you said. And what if you can't find a duct, what would be your differential diagnosis?
If you can't find it?
If you can't find a duct, what might you be thinking? If you can only find the stroma with the spindly myoepithelioid cells.
I don't know, like that much mucin, like I just think of like mucocele almost, but that looks different. I mean, you have your mucophages and everything. I don't know. Like, I mean, so I know what I might do. I might, well, like P63 could help like line the ducts, but I don't know what I would specifically be thinking of.
Anybody else?
Like a myoepithelioma?
Right. So we don't think about this diagnosis too much in salivary gland, because generally when you find something that is a myoepithelial cell-rich tumor with myxoid stroma, generally you're going to see a true duct somewhere. And so true myoepithelial pure tumors of salivary gland are, in my opinion, extremely rare and perhaps non-existent unless they're myoepithelial carcinomas. And so as you can see here, we can pretty much see, oops, where's my annotation? We can pretty much see that at least focally, there are these more eosinophilic epithelioid ductal cells with perhaps, scattered myoepithelial stuff at the periphery, even though it's not perfect here. I think we do see that there is punctuation. Oh, here's another one. There is punctuation by these ducts. Therefore, it is a true biphasic salivary gland neoplasm. Therefore, it is a pleomorphic adenoma. But yes, I would agree that if you don't see the ducts, you are allowed to make the diagnosis of a benign salivary gland myoepithelioma. As I said, I don't think true benign myoepitheliomas are very common. I think if you have a myoepithelial pure tumor, it's more of a myoepithelial carcinoma, excuse me. Question, yes, you said myoepithelioma in the comment, yeah. Questions or comments on this guy before moving on? So again, two commonly encountered tumors that are benign, that generally a good diagnosis can be made on biopsy. I would argue with the exception of the occasional overlapping features that we see in a pleomorphic adenoma. as exemplified perhaps by the next case. All right, so anybody, maybe either a junior or a Hairmore senior want to take this one. In a 46-year-old female with a mass of the right parotid and jaw discomfort. If not, I'll start calling on people. Oh, hey, Kevin, how are you doing? You want to answer a question? Or are you busy doing stuff?
Oh, I'm all right. I'm happy to be here, but I'll happily let the actual residents.
See, the interloper gets called on. No, just kidding. How about, who's out there? Heather, Chief.
Oh, hey. Okay, so I'll try. So, you know, on low power, it kind of looks like our previous core. You know, like a pleomorphic adenoma. But then when you look on higher power, it looks, you know, a lot more cellular. In terms of if it's biphasic or monophasic, you know, I think it looks so we've got these like ductules or what attempts to be ductual. So I don't think this is a myoepithelioma. You can kind of cross that out of the list. Other things I was thinking of was maybe an adenoid cystic, just because of how rigid these ductules were. But this one I think is like a little less clear cut than the one we had prior in terms of like if it's low grade or high grade. You know, the nuclei I think overall look low grade to me. They don't look like mitotically active or too pleomorphic. Let's see, and then it's a mass in the right parotid and jaw discomfort. Let's see what else is there. So thinking of what it could be a myoepithelioma possibly, but
what?
Oh, sorry. What do I have written down here? Myoepithelioma. Probably no. That's probably not correct.
Right, so if maybe you're thinking about the breast.
Yeah, I think I am.
Adenomyoepithelioma. What is that in salivary gland?
That is a oh gosh, is that a salivary ductal carcinoma? Is that we're thinking of, or intraductal carcinoma? But that's not what this is. Yeah, PA basically. Never mind.
A benign biphasic salivary gland neoplasm in the breast, adenomyoepithelioma; in the salivary gland, pleomorphic adenoma. Okay.
Yeah.
So what are our other? Do we think morphologically this is biphasic? Yeah.
Yes.
All right. So what are our other options?
Let's see. What other options do we have?
Ooh, let me move this aside. I think you mentioned one of them.
Adenoid cystic is one of them. Yep.
One other malignant one.
Polymorphous low grade.
Is that monophasic or biphasic?
Oh no, it's monophasic, I think. Let's see what else would be there.
So I have a type of MEC in the comment. I assume you mean
mucinous
mucoepidermoid carcinoma.
Yes.
Do you see any intracellular mucin?
I saw kind of clear cells, but I'm not sure if they are myoepithelial cells. Or, the cells appear clear, the cytoplasm is clear, and it is cytoplasmic. But myoepithelial cells could be clear as well.
Right, so myoepithelial cells could have clear cytoplasm, which doesn't necessarily contain a discrete mucinous vacuole that has that sort of blue tinged mucin in it. This is more sort of fuzzy, I would argue, kind of fuzzy clear. And also for mucoep, do you see any squamoid cells?
No.
No, not really. So I would argue that that's less high on my differential. But what is one other malignant biphasic salivary neoplasm?
Like we could think about a basal cell adenoma, but I don't think this is what
Okay.
it is for an epithelial carcinoma.
Yeah. So those are all totally true biphasic neoplasms. So, oops, I don't know why I can't get back to this one box that I'm in. Here. Yes. So basically, here we go. Epithelial myoepithelial carcinoma is another prototype biphasic salivary gland carcinoma. Any type of basal cell neoplasm, right? That is also biphasic, but I think, as Heather said, I agree. What's missing here that usually is present in basal cell neoplasms, either adenomas or carcinomas?
Like basement membrane material or?
Yeah, so the very eosinophilic basement membrane material, as well as those kind of jigsaw puzzle architecture, right? This is, how would you describe the architecture in this case?
More trabecular, honestly. Trabecular to tubular.
Yeah, so there are tubules and ducts. There are these trabecular cords of sort of individual cells streaming within this myxoid background. So I think this is a good differential diagnosis. Do you want to do any stains, or do you want to just give a diagnosis on this? And I think either would be completely reasonable.
I think we could just do, confirm it's myopathy or epithelial. So we could do a P40, 63 c-kit. And then for adenoid cystic, we could do a c-kit.
Okay. All right. So here, let's work with those two. So here's a P63.
Okay. So I now know that there are epithelials or myoepithelial cells.
And I think importantly, when evaluating P63 or P40, look at the location of the positive cells versus the location of the negative cells. And sometimes it seems haphazard, but at times you can actually make out, right, that the cells at the periphery are the myoeps, and the cells at the center are the epithelial cells that are negative for the P63, P40. Yeah, so that distribution, here's a good one. That distribution, right, is very important. Okay, and so then you also wanted a c-kit.
Yeah.
Which I think we have. Yeah. So what do you expect for c-kit in these biphasic neoplasms?
Be in the epithelial cells. So looking here, we have cytoplasmic staining. And then they are highlighting the epithelial cells and not the myoepithelial cells.
Yeah, arguably these guys out here are the myoeps and they are not staining. And exactly, the guys in the center are staining. So excellent. So we've confirmed the biphasic morphology. And anything else you want for the time being?
S100 possibly.
I think I have an S100, but it is not going to be specific. It's sort of going to be packed here and there without any distribution.
I guess a P40 possibly. I feel
that would function exactly the same in this case as a P63. Yeah.
See what else is there. Possibly do.
So we have a comment here for myoepithelial carcinoma. Right, no palisading like you'd expect in basal cell neoplasms, and maybe genetic testing. So yeah, so I think we've excluded perhaps a pure myoepithelial carcinoma because of the biphasic distribution, which you can see nicely in these ducts. And Christina, on genetic testing, what would you be thinking about? Plag. Okay, so plag rearrangement could help you for a pleomorphic adenoma. Totally. I think that, unfortunately, the plag immunostain is so bad, and the plag rearrangement would certainly be diagnostic of a pleomorphic adenoma originating tumor. However, I don't think that in this case, our OncoPlus fusion panel is going to take 2 months, and they're not going to be willing to wait that long. Theoretically, you could try FISH, but I don't think FISH for plag exists out there in the world diagnostically because the utility isn't very strong in terms of use case scenario. I know, right? Dang. We always want to know, but most PAs are PAs, and they're easy to diagnose. And so we don't generally use plag rearrangement. EWSR is seen in what type of salivary gland neoplasm?
Clear
think-
cell.
Pardon?
Something with clear cells.
Oh, yeah, clear cell
Something with clear
hyalinizing.
Hyalinizing.
There are two types of neoplasms that have EWSR gene rearrangement. Those are just clear cell carcinoma, period, used to be called hyalinizing clear cell carcinoma, and then clear cell variants of myoepithelial carcinoma, right? So I'm just going to type it in the chat. So EWSR ATF, EWSR1 ATF1 is present in the clear cell carcinoma, and EWSR1 other is present in the clear cell myoep. Okay. All right. So what's our final diagnosis going to be on this case? On our top line?
Low-grade salivary neoplasm.
Mhm.
Yeah, I think, and then you just be descriptive. But then they would excise it, and it looks like they did.
Yeah, so
Excision,
low-grade
yeah.
biphasic salivary gland neoplasm, I think is completely reasonable, but putting that differential diagnosis in the comments, I think is very helpful for surgeons to sort of know what to expect when it comes out, right? Like, could this be a PA? Sure. Could this be an adenoid cystic? Sure. She's got jaw discomfort. It doesn't say nerve pain, but nerve pain could also help you very much to point it more towards an adenoid cystic. So yeah, so here's a resection.
Yeah, it doesn't seem as well circumscribed. I mean, I guess this looks more adenoid cystic now, looking at this resection.
Yeah.
And is that a nerve possibly there? Yeah, so it looks like if there's nerve infiltration, that's definitely not a PA at this point. Yeah, so I'm gonna call this an adenoid cystic just based on morphology or previous immunostains and nerve involvement.
Excellent. Yeah. So this is one where the more characteristic cribiform morphology was really not present very much on the core, is only present in very small bits on the resection, as you can see here. The only evidence of infiltration that we see was really on the resection specimen, where you can see here that, as you pointed out, it sort of infiltrates out here between nerves. It infiltrates, here's like a normal salivary gland lobule, right? It's infiltrating between the normal lobules, which is incompatible essentially with a benign diagnosis, right? So once you see the resection, I think it's a little more obvious, but you can see how that, here's your nice biphasic cribiforming. You can see how in those areas that are stromal rich and myoepithelial cell rich, that there are features that are overlapping between pleomorphic adenoma. What I will say is that sometimes the cytomorphology of adenoid cystic is a little more, the nuclei tend to be a little more darker and wrinkled, whereas, in a PA, the nuclei tend to be a little more open and oval. So you can sometimes use that, but it can be hard on core because, of course, sometimes crush artifact makes the open oval cells even look kind of crushed and small. So here's confirmation. This is, what is this, P40? Is this P40? Yeah, oh, here it is. The P40 is a little weaker than the P63, but you can see how it again highlights this nice outer myoepithelial cell layer. And then C-kit, which should highlight the luminal, oh, here we go, nice, the luminal epithelial cells. So again, demonstrating the biphasic morphology. Remember that the P40, P63 C-kit pattern would essentially be identical in the ductal or tubular areas of a pleomorphic adenoma. So it shouldn't be 100% diagnostic, but it could certainly push you to at least a biphasic neoplasm in context of other stuff. All right, questions or comments? Yeah, so PA and adenoid cystic, can be very challenging to differentiate from one another, but I think you guys did a very nice job. So moving on to the next case. So I don't have a core biopsy here. This was a 64-year-old male with asymmetry of the submandibular gland. And what it was called on FNA, there was no core, was a basaloid salivary gland neoplasm. So again, when basaloid cellular salivary gland neoplasms are seen on FNA, what does that generally imply for the histologic differential? Feel free to type something in as well if you guys want.
Basal cell adenoma.
Okay, so a basal cell adenoma, or when you think about a basal cell adenoma, you always have to think about a
Carcinoma.
basal cell adenocarcinoma. Okay, good. What else?
Adenoid cystic.
Uh-huh. And our favorite mimicker, right? A cellular pleomorphic adenoma. So those are the three sort of main ones when you see basaloid neoplasm that we're going to be thinking about. Just remember that it's not, for the basal cell neoplasms, it's not basal cell carcinoma, like in the skin, it's basal cell adenocarcinoma. So just terminologically, just to point that out. Okay, excellent. So that's kind of what we're thinking. How about, all right, and you guys typed in PA, great. So Reham, since you kind of offered some thoughts, do you want to discuss what you see here on this? Now they sent this tumor for frozen section. As you can see, based on there's a few folds, the morphology looks, you know, a little bit different than we'd see on a regular permanent H&E. But Reham, do you want to describe what you see on the frozen?
Sure. So I'm seeing solid epithelial islands and maybe sheets with very prominent basement membrane deposition. The islands fit into one another in kind of puzzle appearance. And I'm seeing very prominent eosinophilic material within lumina.
Yeah.
Kind of peripheral tumor cell palisading.
Yeah.
So I'm thinking about, I didn't see any mitotic activities or there is no necrosis. So I'm thinking about basal cell adenoma.
Okay.
Adenoid, yeah.
Go ahead.
Adenoid cystic should be in the differential diagnosis as well.
Yeah. I agree with that differential. I will argue, even though, so to recap, there are nicely sort of tightly intersecting islands in that jigsaw puzzle pattern with, as you said, sort of peripheral accentuation or peripheral palisading with very prominent eosinophilic basement membrane material, both highlighting the periphery of these islands as well as sort of these cores in the center of the islands. I agree that you don't see necrosis or very many, if any, mitoses. However, I would urge you to look carefully at the periphery for any possible infiltration.
Oh, here we have infiltration.
Right. So be very cautious with basal cell neoplasms because even basal cell quote unquote adenocarcinomas can be infiltrative, but still very, very cytologically low grade, right? So do you want to maybe modify your?
Yes. So I believe basal cell adenoma, we shouldn't see any invasion. So here basal cell adenocarcinoma should be in that differential diagnosis.
Exactly. So the only way to distinguish a low-grade basal cell adenocarcinoma from a basal cell adenoma is infiltration. And I think you can all see that there are these sort of skip islands of tumor separated by normal gland. So yeah, basal cell adenocarcinoma, I think, is a perfect diagnosis for this and is a lovely, 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 lovely frozen section. This was sent intraoperatively, presumably because one, a firm diagnosis was not given on cytology, but more importantly, even if a firm diagnosis isn't given on cytology, sometimes they really want to know whether it's high grade or low grade, so that they can either do or not do the neck dissection. Invasion not present, totally missed that. Yeah, it's very focal, but you have to look around the whole periphery. And so here's the permanent section remnant of the frozen, again showing this nice dotted right island of infiltration between the normal parotid tissue. And here's the permanent section that again sort of does confirm this lobulated invasive growth. Oh, this is lovely. It's actually sort of tracking along either side of this totally benign duct in the middle, right? So the tumor on top and bottom of the benign duct. So yeah, so you know, interestingly, does anybody? Oh, there's stories about both of these, but does anybody want to see stains? I've got some. If so, what do you want to see?
You do a beta-catenin and see what happens.
Okay, beta-catenin, which one is that? So beta-catenin is number 17. All right, so beta-catenin is here, and what does it show?
It's membranous.
It's membranous. So do you consider that normal expression or sort of abnormal / positive expression?
Don't we need to see nuclear staining?
Exactly.
The peripheral cells, like the myoep cells at the edges.
Yep. So nuclear expression is what we're looking for, mostly in the myoeps, and we do not see it. So we can perhaps assume that this particular basal cell neoplasm does not have a beta-catenin mutation. And if you remember, the beta-catenin mutations are more found in the benign adenomas, but could certainly also be found in the adenocarcinomas. What's the other marker we sometimes use in conjunction with beta-catenin?
The left one.
Right, so this is the left one, which in fact is nuclear positive, highlighting not only the peripheral, but some of the central cells as well. So I haven't had as much experience with the LEF one, because to salivary, it's a relatively new concept. So I'll have to keep, you know, if we have these kinds of tumors, we'll try it out and see what things look like. But at least there is some LEF1 staining that theoretically could support your diagnosis. As you can see, it's negative out here in the normal. And oh, look, it's staining the lymphocytes. As we know, this is used in heme for our, I'm not even sure what, but I know that it was originally developed for heme malignancies. If you want to see a I think this is a P40. Yeah, so this is a P40 showing some nice myoepithelial cell staining. There are some cells at the center of these nests that are negative. You can get variable intensity of P40 in basal cell neoplasms. Sometimes it really only highlights the peripheral cell layer. Sometimes, as in this case, it's more robust and only few cells are negative. So just keep that in mind. Here's, again, for our biphasic stuff, here's a C-kit. As you can see, again, it's not quite as crisp or as clear as it is in the PAs and the adenoid cystics. It definitely stains some of the quote unquote myoepithelial cell component as well. Maybe it's a little bit stronger in the epithelial cells, but definitely not as crisp or as clear. So yeah, so we have a diagnosis of basal cell adenocarcinoma. Both the case above and this case had some sort of diagnostic challenges where either the core or the frozen were, you know, considered to be something that ended up it not actually being. So don't ever feel bad if you stick your neck out and you get an incorrect diagnosis, because, you know, it does happen. It does happen. So the more cautious you can be on a core or on a frozen is to your advantage, with the caveat that we are able to distinguish high versus low grade, at least in most cases. And you don't ever have to stick your neck out if you don't feel comfortable. But if you do and you're wrong, it's okay. It happens. So just, you know that it's okay. Questions or comments? I got a call from the grocery room. I don't know if they're wanting me to look at a frozen or what. Can I give control to maybe Katie, and you can work through the next case while I call the grocery room back?
Yeah, sure.
Thank you. Let me just mute myself.
All right. So this is on a little bit of a delay, but I think that we can kind of get through it. So this patient was a 89-year-old female with a nodule of the retromolar pad. And does somebody want to describe what we're seeing?
Do you mind spinning it so the squamous epithelium is on top?
Mhm.
Not to be picky or anything. I can give it a shot.
Great, Christina.
Yeah. All right, so we have squamous epithelium that does not seem to be currently involved by this whatever neoplasm we're looking at, and it's not coming from the squamous epithelium. It's all underneath, and it's not really well defined or encapsulated. It's kind of just all over. It is, let's see, it is more, I don't know, would you say purple or amphiphilic? I don't know. It has, it's not growing in kind of like in the previous case, like jigsaw puzzle or anything like that. It's more like trabeculae, and it's trying to form little ducts maybe, or glands, something like that. A lot of the spaces that it forms are not filled with secretions. Let's see. The cells sort of look monotonous and more ovoid than anything else. Definitely not spindled. I didn't see a lot of what I would call pleomorphism within the cells themselves. Yeah, some were a little bit bigger, but there was nothing like standing out, crazy nucleoli.
Right. So no like high grade features, right?
Yeah. The cells having distinct borders, so it looks kind of like a syncytial growth. And let's see. I didn't see necrosis, and I tried to look for mitosis, but I struck out.
So do you think it's a monophasic cell population or a biphasic cell population?
I think it's a monophasic cell population. And I sort of tried to put it in the microcystic to cystic to secretory category. But I could be totally wrong.
Okay, so then did you want some stains, or are you ready to call it something?
Oh yeah, so kind of like I thought of mucoepidermoid carcinoma.
Okay, so starting with mucoepidermoid carcinoma, how many cell types does that have?
Wow, it has 3, but I don't think this is it.
Yeah. Okay.
Then in the differential of that subcategory, it's like you have the introductal carcinoma, a cynic cell, and secretory carcinoma. But I don't think I was able to like just outright say what the diagnosis is.
Okay. Did you want some stains?
Sure. Maybe like an S100.
Good choice.
Okay, I just want to make sure I'm clicking on the right one.
Yep.
I think we have an S100.
It looks like super strongly positive.
Looks super strongly positive.
Yeah. Then I think that the cynic cell would be ruled out based on that. That's what I think.
Okay. Would you want anything else?
Yeah. How about just a P63 or P40, whatever you got?
Okay. We have a P40.
Oh, that looks.
Which we know worked because we have our positive control in our little basal cells of the overlying epithelium, and it looks.
Well, that looks disappointing to me. But...
Yeah, disappointing.
Yeah,
Acting, Christina.
darn it. You know what? Then this cannot be. Okay, so if it was introducto and we had super strong and diffuse S100, which we did, but P40 at the periphery of whatever this lesion, definitely dead negative. So maybe I can rule that out. I don't
So
know.
think about that. I think I have a table of strongly S100 positive tumors,
Ooh.
which some people are typing some options in the comments. So if you are lost, but you have this diffuse strong S100, think about that table of diffusely strongly S100 positive tumors. And I see both, I see Ryan and Perry and Heather all saying polymorphous, PAC. So,
Oh yeah. Okay, cool. Thank you guys. Totally
so tell
appreciate
us, so Perry, tell us why polymorphous.
I think it kind of fits with this picture. We have a single cell type. We have this super positive S100, and then there's no staining for P40. So I think all of that kind of supports that as part of the differential.
Absolutely. And so the polymorphous is so called because it can have polymorphous or heterogeneous architecture, but a monotypic cell type, unfortunately. So yes, it does have this cystic or microsecretory type of pattern. So it can definitely fall into that differential diagnosis, but it's also very cellular. So it can also fall into the sort of basaloid category, right? And within the basaloid category, polymorphous is one of the only ones that does not have a biphasic population. Within the microcystic or secretory, there are, as you said, a number that do have a monophasic population, but really very few are strongly positive for S100. And so remember that polymorphous and its counter pseudonym outside the palate is also called cribriform adenocarcinoma. They both have similar morphologies. Sometimes it's said that they have what kind of nuclei? I don't think I mentioned this in the lecture. And in fact, I don't think we see them here. But sometimes they're said to have PTC-like nuclei that are very oval with chromatin clearing and grooves. This chromatin is much more, stippled, not really clear. So it doesn't really apply in this case, but yeah, vesicular. Good. Questions, comments? Remember, polymorphous is most commonly seen on the palate, but is not the most common tumor of the palate. And in this case, where did it come from? Retromolar pad. Yeah, so kind of up, nearing the palate, Any other comments? Cool. Katie, you want to keep going with the next one?
Sure.
Apparently whoever called me figured out what they needed from the gross room, so they don't need me.
Okay, so this one was a 69-year-old male with a mucocele of the upper lip. That's what it was diagnosed as clinically. And I can flip it around again. Does anybody want to take a stab at this one?
I can talk about this. This is Magna. Can you guys hear me?
Okay,
Yep.
great. Yep, we can hear you perfectly.
Yeah, so on low power, you saw the well-circumscribed lesion. There's sort of like, I guess, one main nodule there with some lobules. So if you go a little bit higher power, you see sort of these spaces that are filled with this grayish material. And the cells around are oval and do have sort of like a vesicular the nuclei have a vesicular quality to them. And so to me, immediately, I guess you could think about adenoid cystic, but it doesn't quite fit morphologically for that. Morphologically, it actually made me, the spaces look a little bit more cribiform. So I was thinking about something more cribiform. So maybe the cribiform variant of polymorphus or adenocarcinoma of the salivary gland is where I was leaning towards with this, just because of the kind of.
Okay, I think it has a little bit more of like it's a little hard to tell, but some kind of smaller cystic areas versus.
Yes.
Yeah.
Actually, mucoepidermoid would also be in the diagnosis. Thank you, Perry, or in the differential.
Yeah, sure. The only thing with mucoepidermoid carcinoma was anybody able to see any cells with mucus in them?
Not really.
Yeah, not really. So you can have more cellular and more microcystic architecture in mucoepidermoid carcinomas, but you should also always be able to find at least one mucus cell or goblet cell.
Another thing to think about is secretory, although the morphology didn't look as high. Well, microcystic pattern sort of made me think of it, but I just didn't think that the nuclear features were matching, but I guess there could be some variation there.
What would you be expecting? Sorry, go ahead, Luke.
I was going to say, I agree with the microcystic pattern, and could it be a actinic cell carcinoma, which can have a microcystic pattern, which is just something I would add to the differential.
Yep, Heather mentioned that too in the chat. So Magna, would you want any stains?
Yeah, sure. Maybe we can do a C-kit and a P40.
Okay, I have P40. Oops. This is P40.
Oh.
Okay. So again, we can see, our internal control in the basal cells is positive, so that's always good to check. But in our tumor, it is too far.
So could polymorphous cribiform be on the differential again? I guess, because sometimes that one is negative for P40, although zooming in, I don't know if you're trying to show me some kind of blush patchy staining.
No, I think this can just be ignored as non-specific staining, or maybe entrapment of surrounding ducts, like at the periphery over here. Yeah. We definitely have some kind of entrapment, some normal ducts.
So I think to take home with real quick, to take home with this case with P40 is that if you are thinking about a microcystic go-up, really you should have P40 or P63 significantly staining. With the absence of P63 or P40, or just a few, in this case, I agree, it probably is just entrapped ducts because it's not very, there isn't very a rich P40 population here. You could still definitely think of secretory. You could still definitely think of a microcystic variant of a cynic cell. You could still think of polymorphous. I would argue that usually polymorphous isn't quite so secretory / tubular. This is a little more tubular, secretory rich, but those are all definitely possible just based on this. So yeah. Other?
Maybe we can do an S100 then, just because polymorphous is in the differential and we have the negative P40.
So this is our S100.
Oh, well,
so
I think that's diffusely positive.
Right, so you still have polymorphous and you still have what else on your differential?
The cribiform variant.
So polymorphous / cribiform, right, and secretory, correct. And thankfully, this also kicks off what other one?
Cynic cell carcinoma.
Exactly, right. So this does kick off the microcystic variant of a cynic cell. Reham mentioned PAS diastase, which could also help if you don't see zymogen granules. But S100 would do this same function.
So I think we still have 2 left. So Magna, is there one more stain that you would want to differentiate between the polymorphous adenocarcinoma and the secretory carcinoma?
I think. Yes. I'd like to do, well, okay. Immediately I'm thinking about androgen receptor, but I don't know if that's going to help us differentiate.
Typically, androgen receptor is positive in salivary duct carcinoma. But Brooke just said in the comment, mammoglobin. And so yes, so this was our mammoglobin. So positive. So this, with mammoglobin positive, what would the diagnosis be? All right, Reham in the chat. Yes, secretory carcinoma. So this case, I think, you know, clinically is very important because the clinician thought that this was a mucocele. And in terms of doing a surgical biopsy for a mucocele, they did an appropriate job, right? Because they got some minor salivary gland tissue here. But, you know, this goes to show that just because something clinically might be indolent, that doesn't always mean that it's going to have an indolent diagnosis. I've also seen mucoepidermoid carcinomas that are a little bit cystic that have presented as kind of mucoceles of the upper or lower lip. So definitely things to take into mind.
And I think that in this case, it's so well circumscribed, right? Like on low power. But I think that P40 really highlighted the fact that it really did entrap some of those peripheral ductules, right? So this is truly an invasive carcinoma, even though it appears quite circumscribed, and it warrants the diagnosis of a low-grade carcinoma. Yeah, perfect. This is one where when this diagnosis was first described in the 2010 or 11, you know, we were doing ETV6 fish or NTRAC, but mostly ETV6, I think, because that's the common partner, to confirm this diagnosis, right? Because it was sort of new to everyone. And we had ETV6 fish from our other, you know, fibrosarcomas and our other neoplasms. And so, you know, we were doing the genetic studies in the early days, but sort of after getting a handle on this diagnosis with morphology and with immunostains, we sort of stopped doing the fish because again, you could really make a diagnosis based on the morphology and the immunoprofile. But the fish in this case is out there. Tiny memory trick for board/life. Secretory with ETV6. Nice. Thanks, Kevin. Nice. All right. How are we doing? We're already at 9 o'clock. So I'm happy to continue the last few cases if people want to stay on, or we can, you know, send out the answers, or we can do it sort of quickly. Anybody have any preferences? I'm gonna grab this from you, Katie.
We can finish, I think, since it's being recorded anyway.
All right, it's being recorded, so we'll finish. Now we're on 26, which is 72-year-old male with a mass of the parotid, and this was, oh cool. So we only have 2 more cases left. We have 7 and 8. These are great in continuity because the differential diagnosis of cases 7 and 8 is quite overlapping. Okay. Who wants to do at least a description? Oh wait, what's the first thing we notice that we haven't seen yet?
I can describe a little bit.
Yeah, go for it.
So here I think we have this junky, I'm concerned about necrotic material where we were before. And then the sort of tumor proper has these rather pleomorphic looking cells with a number of mites and just sort of scary looking nuclei, high-ish N to C ratio. Cells look a little like vaguely spindled in some places, but I don't know that I would really hang my head on any of that. Well, actually, maybe I would. They do look pretty prominently spindled out here. Yeah, I was remembering from, yeah, that area, maybe less so, but here, yes. And again, just like dreadful looking nuclei. And I don't remember how many mites I counted last night, but there were quite a number of them.
When you start seeing more than one in a field for salivary gland, worry. Sorry, go ahead.
And I think, yeah, in terms of like, yeah, we have a number of very sort of atypical looking mites and atypical, highly atypical looking cells. And again, that candidate necrosis going on, I think, as well, and more spindling.
So what's the most important thing you can tell them on this biopsy?
It is high grade.
Yep. So what are the most important features that are sort of common to all high-grade salivary carcinomas?
The presence of necrosis, mitoses, I mean invasion, but we can't really evaluate that here.
Right, and you can have invasion in low grade, so.
Okay. So yeah, I'm thinking what else other than mites and necrosis?
What kind of invasion might push you more towards high grade? You're welcome, Christina.
Like an infiltrative pattern as opposed to like a pushing pattern?
How about like a invasion?
Oh, like PNI?
Nerves and vessels, right. Right. So I would argue that these features, when you see them, be very cautious. Things like perineural, you can see in other low-grade carcinomas, especially like polymorphous, right? But in general, I would always note when you see perineural or vascular, certainly necrosis and certainly high mitotic activity, or not even high, just evident mitotic activity in some cases is unacceptable. So good. All right, so you're going to call this a high-grade carcinoma.
Yes.
You think it is this is a person, what, in the parotid. Do you think this is of salivary type, right? Because we know that carcinomas can metastasize to the parotid. Does this look like it is possibly of salivary type?
I mean, I think it could be, but given how sort of ugly it is, I guess we couldn't put it past being a met from elsewhere.
True. I think the things that suggest salivary origin are perhaps the myxoid stromal background. Certainly spindling you can see in various types of tumors, including metastatic melanomas and squamous cell carcinomas.
But we could imagine, yeah, we could imagine these being sort of spindled myoeps, I suppose. So
exactly. All right, great. So high-grade carcinoma, they're going to resect, and assuming that the patient doesn't have any other carcinomas elsewhere or melanomas elsewhere, they'll probably treat this as if it were a primary and probably do a resection and a neck dissection. And so here is indeed the resection specimen showing these multiple lobules, which are compatible with sort of infiltration of pre-existing parotid. And plasmacytoid appearance. Yeah, I think some of the cells had a plasmacytoid appearance with sort of eccentrically located nuclei. All right, so let's keep looking around, and whoever has any thoughts or wants to order any stains, shout it out or type it in. Here's more of those spindled pleomorphic areas. I don't think we had any stains on the biopsy, but we do have stains on the resection, so we can just go from there. Ooh. Big nucleoli. Okay, so prominent nucleoli are also very important in salivary gland neoplasms because you really don't see those in our regular run-of-the-mill benign salivary neoplasms. Once you start seeing prominent nucleoli, you're thinking about malignant transformation or already malignant. Brooke.
We can start with a P40 or C-kit.
Okay, good. So we have our sort of general pattern that we work through. So this is a P40. Do you see any particular geographic distribution to the P40, or is it sort of?
It's pretty scattered.
Pretty scattered, but pretty everywhere. All right, and I think this is is this a P63 next? I think so, 29, yeah, that is.
Yes, P63.
Thank you. So, P63 tends to be stronger than P40 in a lot of instances, but also less specific. As we know, just as a reminder, P63 can be polymorphous and positive. P63 can be positive and polymorphous, even though P40 is negative. In most other tumors, it functions identically. As in this case, it essentially functions identically with P40 being somewhat stronger, P63 being somewhat stronger. Excellent. What else do you want? And or what are you thinking with these being positive? So Reham said myoepithelial, Luke said S100. All right, so do we have, oh, we do have an S100. So we definitely have some expression of S100, kind of patchy, but not really diffuse and strong, but sort of patchy, which, you know, can happen. What would you be thinking for myoepithelial? So you can get P40, P63, and S100 in myoepithelial, yes?
Calponin?
Calponin or a myoid marker, yeah. So we have both. I think we have SMA and calponin. So let's start with your, where is it? Is this your calponin? Yeah, this is your calponin. So again, some of these spindly cells are calponin positive. Some are a little bit weaker. Calponin tends to be, ooh, look, nicely highlighting the normal contractile cells. And focally highlighting the tumor cells. Going along with calponin, let's also throw in SMA. SMA, again, kind of patchy and focal, but just focally there. So do you guys have any more concrete thoughts? Here's your SMA. Yeah, I would argue these are tumor cells, right? They're staining around the large nuclei. And I think the other thing we have is it's a keratin. Is that what this is? 32. Oh yeah, 32 is a keratin. All right, so what's your diagnosis? Or do you still want more? So we started with, right, we started with this and we ended with this. No one? No one has a diagnosis?
Could we think mucoepidermoid for this one?
Could we think mucoepidermoid?
No.
If we saw intracytoplasmic mucin.
Yeah, which I'm not seeing again. Right. Never mind.
Usually mucoep is also not this spindly, but I think you said it before, what tumors of salivary glands can be very spindly and or very epithelioid. that this profile would fit for? Tom's got it already in the chat. I mentioned before.
Myoepithelial carcinoma.
Yeah, would myoepithelial carcinoma fit in this case?
I believe so.
Yeah. Oh, sorry. I thought you said, yeah, I did not say that. Rehab should get the credit. She's the one who said that before.
Yeah. So
confused. Yeah.
So myoepithelial carcinoma, I think, is probably the best answer in this case. It's got staining for what we expect, like both a keratin and various basaloid and myoid markers, right? So P40, P63, a little patchy SMA, a little patchy calponin, a little patchy S100. And so remember that the immunoprofile of myoepithelial tumors is very variable. The morphology of myoepithelial tumors is very variable. And the only other, diagnosis that you could that I would consider with strong P40, P63, and keratin might be like a weird mixoid variant of a metastatic squamous cell carcinoma. But, in the presence of no skin cancer, in the presence of SMA and or calponin, this probably fits best for a primary salivary myoepithelial carcinoma, which, as you know, can be epithelioid, can be spindled, is often high grade, and characteristically has this mixoid pale background, right? So when we talked about stromal mucin in the pleomorphic adenoma, it was the myoepithelial cells of the pleomorphic adenoma that were, of course, secreting that stromal mucin. And it is, again, the myoepithelial cells here that are producing it. Why poor S100? Because myoepithelial cells are not, they don't always fit the same pattern. So where is the, let me find 33. Yeah, this is it. So unfortunately, myoepithelial cells don't always follow the exact immunohistochemical profile that is always described for them. So even if you read, for example, like Fletcher's paper on myoepithelial carcinomas of soft tissue, they don't all express all of the relevant markers, right? So it's sort of a grab bag. Like in bag 1 is EMA and a keratin, and in bag 2 is S100, GFAP, P63, P40, calponin, SMA, and you just need essentially one from each bag. More often than not, you have more than one from the second bag, but because myoepithelial cells, their immunoprofile kind of varies depending on their morphology and what they sort of choose to express at that level. You don't always have to have strong S100. So for example, if you are a plasmacytoid rich myoepithelial neoplasm, though plasmacytoid or hyaline myoepithelial cells tend to be much more strongly S100 positive than the spindled myoepithelial cells, for example. So when I'm trying to diagnose a myoepithelial carcinoma, I always use a number of immunostains, because you never know which one you're going to get to be positive in that tumor, if that helps. That's why these are tricky. They're sneaky. Does that help? Okay, cool. And the last one, Katie, do you wanna take over the last one?
Sure. Okay, so I think we actually had 2 H&E cores for this one, but we ended up doing most of the staining on this first one. Okay, so who is left and wants to describe what we see?
I can describe again. The core is, like the entire core seems to be composed of lesion. It all looks about of equal density of these spindle cells with blue bland nuclei arranged in sort of a short fascicular undulating pattern. I don't recall that I saw mitoses, at least not a ton, or necrosis. And a little bit unlike the last one, the stroma, I mean, kind of in the middle of the screen that we were at, it's a little bit mixoid, but it's generally a little bit more pink-blue than the previous case.
Definitely. Let's take a peek at the second one and see if that gives us any additional.
So they went and did another set of cores on the same lesion?
They actually did 3 at a time. So I believe there were 3 total blocks, but most of the staining ended up being done on that one with the single core in it. So that's why we sent that one out. But so do you think that this looks the same or different?
I think it looks similar. For some reason, the stroma looks a little pinker, but otherwise the same.
Yeah, it might be the staining. I believe that this was an outside case, so this might be their staining, and the prior might be our staining. So that might be why there's a little bit of a difference. All right. But on core, so if you had to give it like a one-line diagnosis of not necessarily a specific entity, but just something, what would you call it, bro?
Spindle cell neoplasm needs stains.
Awesome. Okay, what stains would you like? We have a few.
Well, I guess my first question is this even, can we say whether or not this is a salivary primary?
Well, that's a very, very good question. For the history, it was a 38-year-old female with a 4.3 centimeter mass of the superficial lobe of the parotid extending into the deep parotid. So in terms of imaging and where they're taking this core, it's certainly within or directly adjacent to the parotid gland, but what would be your other thought if you don't think it's salivary primary?
Right, something soft tissue, maybe smooth muscle in origin.
Okay, maybe smooth muscle in origin. All right, and then somebody said SMA, so let's see what we've got. I think, so we have a calponin. Let me find that.
Which is 41, yeah. Yeah, so I think when something doesn't fit what you normally put into a box for a site, right, you always have to think outside the box, because things can happen anywhere, right? Mesenchymal tumors can happen anywhere. Tumors can be metastatic to places where they don't make sense. So I think thinking broadly in this case is good.
Yeah, so we do have a calponin, which this case was also very difficult to interpret stains because, you know, we can see that it's positive in some areas, right? So calponin would lead us towards, like Brooke, kind of what you said, like some kind of soft tissue, smooth muscle thing, or also positive in what salivary gland, or what salivary cells, I guess we could say.
It would be myoepithelial cells. I don't know the
exactly.
term.
Yeah, exactly. So what else would you like to see? So that was our calponin.
Do we have a C-kit to rule out epithelial cells?
We do not.
We have an EMA.
We have an EMA.
Okay, so negative.
Yep, negative. We also have, I can just tell you the other ones that we ended up doing for this one. We have an S100, which is this one, which is pretty nicely positive, but similar to the calponin, you can see, you know, whether it's preservation of these tissue cores or, you know, some kind of loss, it is kind of staining a little oddly, right?
Yeah, do we have a SOX 10?
Yes, we do.
So what are you thinking with
Pecoma?
What?
Pecoma?
Pecoma? Is that generally spindled? I don't know. I don't usually see those.
I don't know. I was just thinking melanoma markers and smooth muscle markers.
Okay. So back up a little, melanoma markers and smooth muscle markers. So in the salivary gland, what do the combination of melanoma, quote unquote, melanoma markers like S100 and SOX10 and smooth muscle markers like calponin, where does that actually put you back?
So myoepithelial something.
Myoepithelial would be a salivary gland tumor that would do that exactly. However, when you have something that is quote unquote melanoma, right? Like S100 and SOX10, then what else do you want to think about, especially if it's spindled?
Well, melanoma.
Okay, and?
Something like a neurofibroma or schwannoma.
Okay, like a nerve sheath tumor, exactly, right? So neural crest markers, S100, SOX10, especially for spindle cell neoplasms, when you think about a melanocytic, you want to think about a Schwannian. And, you know, arguably, did we see prominent nuclei? Did we see mitoses that might make you think of a melanoma? Or did we see bland nuclei with not many mitoses that might make you think of something more low grade?
Something more low grade.
Something more low grade, fair enough.
Yeah, so here's our SOX10. Again, you know, this lesion looks very monotonous, but the staining is a little bit off, which unfortunately happened in most of the stains, but we can see that SOX10 is definitely positive. All right, so Brooke, would you change your line diagnosis or would you add your differential in a comment?
I don't know what the convention is for this, but
well, what did we say on case 1? Just kidding, or case 2? You don't ever have to stick your neck out on a salivary gland, right? So
okay, then I'd probably keep low grade spindled tumor and elaborate in the comment.
Exactly, and that's exactly what we did. So then this patient went to the OR. I believe we probably added a comment like defer to anticipated resection specimen. And so she did go to the OR and some portions of her tumor were frozen. And so here, looks similar or different to the core, Brooke?
It looks quite similar. If anything, I'd say the spindle cells now look a bit story-form in architecture, but otherwise the same.
Yep. Otherwise, yep, I agree. It's the same. All right, so there was one frozen. Here was another. The frozens were composed of, you know, kind of like what you said in the very beginning, Brooke, all tumor, right? So we don't see any normal parotid. We don't see any adjacent fibrous connective tissue or adjacent adipose tissue. And here's our permanent. There's a little bit of adjacent fibrous connective tissue here.
That's a lymph node.
Oh, that is a lymph node. I don't know why that one got scanned. Whoops. All right. And so now we can see definitely still spindled, right?
Yes.
A little bit. What do you think about the cellularity?
Medium.
Yeah, but yes, okay, medium, but it is fairly cellular, right? We have lots of nuclei. And maybe in some areas we have a hint of palisading, and then some areas that are a little bit less cellular, right? Like this area where you see no nuclei.
Oh.
Like Anthony A and B.
Exactly, Reham. So this was another portion of the permanent that we did staining on, but again, you know, most of this lesion is composed of this very cellular spindled proliferation. And really only in a few spots did we see, you know, any kind of hint of palisading, and then the Anthony A and Anthony B tissue. So
one other feature, at least on these chunks of tissue that are helpful. Can I take over for a second? I think they were only present focally. Maybe there. see if I can find what I'm looking for. Yeah, maybe here. Seems to be maybe a vague hint, a vague suggestion of some accentuated hyalinized eosinophilic material around the vessels with that storiform pattern. So based on the things we talked about earlier, I think you guys kind of are getting what we're getting. Ah, there they are. There they are. There's the hyalinized vessels. So yeah, so Reham has it in the chat. Sorry, Katie, you want to take over and show the stains?
Sure. So yes, we were suspicious of a schwannoma. One stain that we added to the resection specimen was S100, which I think everyone can see is very positive. And then we have our SOX10, again, positive, but kind of, had that odd staining like the core, where some of the spindled areas were negative, but overall definitely positive.
Those could be just endothelial cells of background blood vessels.
Mm-hmm. And then this was our calponin, which we can see positive in the blood vessels, nicely positive in the blood vessels, and kind of just this weak blush, certainly not a strong positive. And then EMA, which I think was focally positive in one of the pieces. But yes, so this was diagnosed as a schwannoma, and this is also a good reminder to everyone just about the anatomy of the parotid gland, that the facial nerve does pass through the parotid. So you can have nerve sheath tumors that on imaging appear to be salivary gland tumors or appear to be within the gland, but yes, are actually nerve sheath tumors and not tumors of salivary origin.
And in this case, when you have a cellular schwannoma, always remember that it sort of, your overlap could be with a myoepithelial tumor of parotid gland. And in this case, the absence of any clear keratin or EMA, right, would essentially exclude a myoepithelial neoplasm. But tissue preservation on core biopsy sometimes makes immunostains challenging to interpret. Weak, weird calponin made this challenging to interpret. But overall, diffuse strong SOX10 and S100 with hyalinized blood vessels and really no good EMA. And I believe radiographically, right, connection to the nerve, put this at a Schwannian tumor. Sorry, was somebody saying something? Cool. Okay, that's it. We can send this presentation out for the full features. Thank you guys for participating. I saw anything in the comments that hasn't been addressed yet. Reham says epithelioma could have spindle appearance. What do you mean by epithelioma? You mean myoepithelioma? No, okay. Okay, I assume that's what she meant. Yes. Okay, cool. Thanks, everybody.
Thanks.